Good evening, everyone. My name is Jane Campbell and I work with the Sunshine Coast Wide Bay Central Queensland PHN, and we'd just like to welcome you all this evening for our Sunshine Coast palliative care updates. Next slide, please. So before we start, we'd just like to acknowledge the traditional custodians of the land in which we work and live, and recognise their continuing connection to the land, waters and community, and we pay our respect to them and their cultures and to elders past, present and emerging. So we'd just like to welcome our speakers this evening. We've got Dr. Louise Welsh from the Sunshine Coast HHS and Wide Bay HHS Palliative Care. She's a physician there. We've got Dr. Johnny Harper, who is a local GP, as well as a GPLO, which is GP Liaison Officer with the PHN. And we also have Professor Liz Raymond, who is the Director of Brisbane South Palliative Care Collaborative. And we've got some other local presenters tonight. We've got Alex Moore, who is the CEO of Chittamani. We have got Amy Cadd from Little Haven in Gympie, and we've got Emma Kerr, who works with Katie Rose Cottage. So we'd just like to thank our presenters tonight, and we look forward to their presentations. Before we jump into the presentations, I just want to invite my colleague, Paige Martinez, who is part of the palliative care team at the PHN, as well as myself. And she also works in the older persons health space. So I'd just like to introduce her briefly, just to give you a little bit of an update of the PHN palliative care program. Thanks, Paige.
Hi everyone, so my name's Paige Martinez and I'm the Manager for Older Persons Health and After Hours Commissioned Services across our PHN. So that does include our palliative care program. So we have recently, as a PHN, been refunded under the Greater Choice for At-Home Palliative Care measure. So a number of you might be familiar with that measure. You might be a part of our interagency steering committees even. We have had funding for this in previous years, but this is new funding as of August this year, and we're revamping what we want to do in the palliative care space from the PHN's perspective. So the main things that we're working on in terms of palliative care are around education opportunities for our workforce within primary care, so general practitioners, residential aged care and pharmacy. We're also looking at working with communities through launching some of the compassionate community initiatives, so things like working with Groundswell, death literacy education,
yes, I've got it.
Death literacy improving. We have also stood up an interagency steering committee once again in the Sunshine Coast area. So that's a committee that, as I mentioned, some of you might already be aware of or might even sit on. But we are really focusing on integration. There's a number of really great things happening in the tertiary space and in primary care with the hospices that you have on the Sunshine Coast. So we're trying to play a role in integrating services and seeing how we can work collaboratively to benefit the community. I'm happy to take any questions on that if anybody wants to pop them into the chat function there, and we can provide any more information around the Greater Choice for At-Home Palliative Care measure and what our PHN is doing. But other than that, I'll pass back to Jane and let the speakers get into it for tonight.
Thanks, Paige. Okay, so we'll press right on ahead and introduce our speakers, or invite our speakers to give their presentations. And if you do have any questions, we do have some time at the end. So if you've got any questions, please ask at the end, or you can use the chat function as well to ask them as we go. Thank you very much. Hope you enjoy.
Paige, will I just ask you to turn the next page?
Next slide. Thank you. Yeah, hello everybody. It's Louise Welsh here, Clinical Director at Sunshine Coast Palliative Care Service. And also I happen to be the Wide Bay part-time position just for something else to do. Thank you, Paige. So just to remind everybody, our Specialist Palliative Care Service is an integrated service for the Sunshine Coast. It's based in our Caloundra hospital site now. There's two arms to our service. As most of you know, we have our inpatient unit and then consult liaison group, which is made up of our SCU inpatient team and our community team. Next page, next slide. So just a little reminder, our Dove Palliative Care Unit is a specialist palliative care unit. At the moment, we have 14 inpatient beds with capacity to go up to another 4, but that's not happening for various reasons at the moment. And we have 4 day unit beds as part of the complex. We do have 24-hour, 7 days a week junior medical officers on site in the ward, and one of the consultants is always available 24 hours a day. And one SMO of our team is dedicated to the ward Monday to Friday. We have a full multidisciplinary team, as a level 5 specialist team should have, so we're very fortunate. So we have our nurses who are well trained, or if they're not trained enough, we certainly upskill them. We have our full lot of allied health, so physios, an amazing pharmacist. So if you have any problems as GPs in the community, please feel free to ring the ward and ask to speak to Roger, our pharmacist. He's a font of knowledge, can give you evidence, journal articles, all kinds of things, and just help you out. We have an OT, dietitian, access to our palliative care psychologists, speech pathologists, social workers, and a wonderful music therapist and a chaplain. Next slide, thanks. So to get your patient in and out of Dove, all admissions are via a treating medical officer. So it can come directly from a GP, another hospital, or a specialist group. Most of the specialists that come in, most of the referrals that come into our service from the specialist teams of oncology and other specialists, usually based in one of the major hospitals. But the rest of the majority is from our GPs in the local district. And of course, we'll have transfers out of district or from the private hospitals and their specialists. As it is a specialist unit, we're here to mostly look after those hard ones. So it's for specialist symptom control for complex patients with complex symptoms. Discharge planning, when they've been in another hospital, we'll take them, what we call, give them a bit of Dove love, tidy them up, sort them out, and make sure that a discharge home is not a bounce back, hopefully, within a few days, that they've got the appropriate community services in place before they leave. And then, of course, patients definitely come to us for end-of-life care, complex or otherwise. To be available to meet our criteria, they must have a NOC for CPR. We are a standalone facility, specialist palliative care. We do not do resuscitation. Occasionally we have patients slip through that they'll come from elsewhere and they haven't completed their advanced care planning and still want full resus, so they're transferred to SCU that day or that night. Of course, they must have a palliative diagnosis. Occasionally we have referrals for people with chronic pain or conditions that are not likely to be palliative in the next 2 years, so they should probably be elsewhere. And we will not take patients who have active chemo. Now, that doesn't mean to say if they've just had their last dose in the last month that they can't come to us. They can be still having a palliative dose of some of the immune therapies but have complex symptom controls. But it must be very clear to the family and the patients that they do have a palliative situation. Otherwise, you can imagine they come into our ward and we're repairing the situation for some days. It's just to give the community a better idea of what we will take. And obviously, because we are a standalone ward on the Caloundra site, we do have difficulty managing severely delirious patients. They will be transferred back to either Nambour or SCU because we do not have the staff at night especially So most of the times we will not actually admit them here until they're, shall we say, they may still be delirious, but they're more manageable. So some of those very, very agitated and distressed patients need to be in a more, sadly, acute environment in the bigger hospitals until they can be managed safely. It's safer for them and it's safer for our staff, and not as distressing sometimes for the relatives either. Next slide, thanks, Paige. So yes, we do allow pets at the discretion of our nurse unit manager. Elephants are not allowed, they don't get through the door, okay? We have had a horse in the courtyard, but please don't advertise that. We got fish, we have cats, we have dogs, and it's mainly along the lines that these are very therapeutic creatures for our patients, and they miss their pets hugely. So it's at our discretion. We can't have yapping or barking dogs, and we're not allowing the cats to wander around, of course, but we do our very best to make this as holistic as we can. During this COVID situation, we have been very, the generous word is liberal with what we have allowed to happen under the COVID situations. But I still, as the director, will put my foot down. Simple things like people who currently have influenza will not be allowed to visit. I know that's sad, but I do not want my ward staff going off with influenza, and I don't want influenza spread around other patients and families. So we speak as directly as we can to families and make sure they understand that there still is a ward through with very sick patients who may want to go home and have time to live. We certainly don't want to be giving them acute infections. Majority of patients and their families we have been able to allow to come out of quarantine and to visit, and that may be repeated visits. There is an assumption sometimes that we have to field from community a lot when the GPs have given the appropriate diagnosis as the patient being palliative. They get their exemption from the Chief Health Officer and then they think they can turn up on the door. It doesn't work like that. They must get permission from the local health service and permission from us to enter the ward so we can have a controlled environment. They can't just wander in off the street or call up a taxi and come from quarantine. Most of the time, the family that are here do talk to us, so we're aware of patients, family members coming from quarantine, and we just manage it through the appropriate process so everybody's kept safe. We do not and cannot go out into the community, neither us or our staff, go out to the community to monitor home visits. Neither do we expect that our nursing staff or like Blue Care, Anglicare or Little Haven be expected to monitor or supervise visits by quarantine patients in the home environment. This is something the HHS is very strict about. These community providers have got enough to do just looking after the patients clinically. We don't want them put at risk supervising possibly infectious people coming out of quarantine. And then we won't pay them for it. It's not fair to them. So HHS is trying to organise an alternative provider to supervise any future. Some of them have happened, but these have been managed by Queensland Health staff, literally sitting on a seat in the yard for 2 hours while that visit happens, ensuring that no other visitors. So there are obvious health precautions to be done. So I just want everybody in the community to understand there are appropriate processes that are done to safeguard both our families, our patients, and our community, but we're as empathetic as we can be. The number of visitors we have, visiting hours and family, we have been, again, more liberal than what would happen into the major hospitals because we are a clean hospital and we want to stay that way. We're fortunate at the moment with 0 cases, so let's see if we can keep it that way. Thank you very much. Next one. All right, we also have a day unit, which is for kind of seated chairs, much like you might see in a renal unit or oncology day unit. This has been set up to try and reduce crisis admissions that can be otherwise sidelined, patients reviewed urgently, tidied up, sent home, people who are palliative but still may continue to require top-up transfusions for a designated period of time with previous discussions with the patient so that they understand this is not going to go on for 6 months or 2 years. So for those people certainly on this end of town, we're happy to provide that transfusion support for them. And it saves them having to go to the big hospitals. It works well for people from kind of Nambour and Maroochydore downwards, but it's a bit of a long drive for people any further north. We also bring patients in for if they're struggling in the community, and we're getting information from our community nurses and GPs that there's a lot of complex things happening and we can't see them in patients in the near future. So we may actually bring them in for a day unit assessment by the whole team. And often this works out that they're reviewed, medications are changed, they get a pharmacy review, education done to the family, the nurses come around, teach family how to give injections, and we send them home with a much tidier package, and hopefully they stay at home longer than presenting to emergencies or coming in on weekends. We've had staffing issues, especially with COVID, so we've had to close the days available, and it has been a larger drain on the consultants than we thought it was with our other duties. So we're hoping that we'll have some staffing help with that. And the GP liaison officers locally are aware that there are some GPs with special interest in palliative care, and there's been a resurgence of funding. So we may be able to look at having a part-time gypsy, as they're called, so GP with special interest, to help us out. So we might be able to have medical cover for that day unit 5 days a week, which will be fantastic. We'll be able to take a lot of the urgent phone calls and patients and families able to come in for an urgent assessment and tidied up and sent home. And often we use it as a patient flow issue. We had a while for family coming to view a deceased patient this morning, and someone urgently needing to come in from the community with symptoms. So we brought the patient straight in by ambulance, and they were seen by the junior doctor and the consultant in the day unit and sorted out, and were quite comfortable there till lunchtime until the other patient was able to be moved. And also getting them out waiting for a family to pick them up, it also works. So that's how we've been using the day unit, and we've got other ideas. It's been going since January, and it's more an internal referral from team members to team members, but just to let the GPs know that it is available there, so you'll need to contact the consultants if you have a patient known to us that you think might be suitable, and do the usual referral through the processes, but call us if it's urgent. Next slide, thanks. And of course, they have to have a not for CPR. All right, our SCU consult liaison team is our mini team. So we have our SMO, it's Dr. Emily Neat at the moment, and our registrar, a junior medical officer and a CN. Sometimes we have another nurse, but we're short on nurses at the moment. So our inpatient team is a consult team. They occasionally will take a patient under their own bedhead, but usually the patients are under other teams. They also do an outpatients on Tuesday mornings at SCU, and our SMOs attend most of the important cancer care MDTs held there to make sure that people that are palliative with the oncology team get the appropriate information. We also are part of the difficult patient multidisciplinary team and also involved in teaching. Next slide. All right, so we have a community liaison team, which is a very full team as well. Referrals accepted from other medical staff. We do outpatients in Nambour, Caloundra, and alternate weeks in Gympie, home visits, aged care facility visits, and telehealth, and obviously teaching. Next slide, please. We are also hosting the Sparta team, which has got a small specialist team, which provides rural and remote telehealth support from specialist team to Wide Bay Central and Central West District. And also one of the SMOs, namely myself at the moment, gives 1 week on, 1 week off, doing ward rounds and outpatients in simply the Wide Bay District to support those districts that don't have specialist palliative care access. Next slide, thanks. We have a new project that's starting now called the Space Team. So we've got Spaces and Razzes and Jedis and Spartas. All sounds a bit weird. Echoes and Rabblies and all kinds of wonderful things. It is a funded project up to 2020 to improve access and provision of specialist palliative care in RACFs. We've just employed someone to start planning this project. Our main stakeholders will be the staff and the patients and carers in the residential care facilities of the district, the GPs that look after them, our Queensland Health RAS team, which is the geriatricians and registrars and nurses that go out to the team to do rapid assessments, and our geriatric emergency liaison officers in emergency. This means we'll have 2 extra nurses in our team specifically for providing education. We're hoping to develop a 24-hour on-call number for nursing support for RACFs, and our SMOs already take calls for this anyway. So it's exciting. It'd be wonderful to have our large number of RACFs providing extra support. Our nurse practitioners do provide support at the moment, but it will give us extra nursing input to those in the district. Thank you. Next slide. What kind of dandelion, what kind of quality activities, just to let you know, we do other things rather than just see patients. We have been integral in developing the Dandelion project, which is the decision making and dying in emergency project. That's been going for 1.5 years, and it is wonderful. It means that patients who come in and who are deemed by decision making flow in emergency to be dying imminently or in 2 hours, 4 hours or 2 days, that a process is made to make sure that that patient is triaged, treated appropriately and managed in the best place that they can be. Even if it is an emergency, there's a flow chart to make sure the emergency physicians have assistance on what to do to allow someone to die in the emergency. The others are just to give you some idea of what other work we do with some benchmarking, quality activities and research. And we have a couple of new plans happening, which is patient health records. So patients can bring in their records to outpatients and we fill them out when they're discharged as well. And we now have a new discharge home to die plan that the GPs and the RACFs may see happening as patients go home. There's an actual plan that tells them what's actually happening. Thank you. I think there's one more, or if any. No, that's it. Thank you.
Thank you very much, Louise. So we'll just introduce our next speaker, who is Professor Liz Raymond. Thanks very much, Liz. Over to you.
Oh, no.
I can get her off mute. There we go. Go ahead, Liz.
You unmuted? Yes. Okay, thanks. Sorry, everyone. I've had a terrible time with this IT. So what I want to tell you about three services that are running, which are not meant to replace your provision of palliative care, nor are they meant to substitute for the services that Louise and Sparta are offering. They're there to actually to help increase capacity for palliative care in the community, and also to augment everybody else's care. So next slide, please. So basically, I'm going to talk about three different things: the advanced care planning in residential aged care facilities, which your wonderful PHN has funded. And the purpose of that is to increase capacity of the RACFs to involve residents and carers in advanced care planning. Then I'm going to talk about Pal Consult, which is actually a 24/7 advice hotline, 2 lines, one for doctors and one for nurses and allied health, in case you have simple questions that you want answered. And Pal Consult also does lots of education, particularly in RACFs. And then the last one is Pallifarm. What we know is that patients in the community or in residential aged care facilities can have trouble getting timely access to meds, and Pallifarm is about encouraging community pharmacists to stock the basic PalCare meds, but also for RACFs, residential aged care facilities, to have impress systems. Could I have the next slide, please, Paige? So the first thing to talk about is advanced care planning in facilities. We know that advanced care planning is really pivotal to resident-centred care. We can't do patient-centred care if we don't know what the person wants for their lives and towards the and for their deaths in the context of their lives. The PHN is commissioning the statewide Office of Advanced Care Planning to mentor up to 30 facilities, a minimum of 4 in Central Queensland, 6 in Wide Bay and 10 in your area, to increase capacity in advanced care planning. So what we will do is we'll have a full-time CNC who's an experienced ACP facilitator, and they will work with the staff of the volunteering RACFs. They'll mentor face-to-face, provide education and other vocational training, and also that will provide support for management in the area of advanced care planning. Could I have the next slide, please? So this is the PAL Consult, which, like Sparta, is funded by Queensland Health. And these are the 2 advice lines that I was talking about. The PAL CR is for nurses and allied health staff. You just go through a Vodafone answering service and then you get connected directly with the specialist palliative care nurse. And similarly, the 1300 PAL-DR line is for doctors and nurse practitioners to speak directly with a specialist palliative care consultant. The sorts of questions that we're getting from GPs is that, you know, you as GPs are managing your patient, but say, for instance, you forgot what the conversion is from a fentanyl patch to a driver with hydromorphone in, and you're just ringing up to check the conversion. We do not provide any services direct to patients. That's for Louise and for Sparta. We help you as much as we can, and we've done an enormous amount of information and resourcing for community palliative care. We've just recently put out a whole subcutaneous infusion education sheet around the NICI T34 syringe drivers. Next slide, please. Sorry, next slide, please. Have I lost you? Hello? Oh.
Can you see the slides moving?
Yeah, I missed the previous one. Can we go back one, please? Yes.
That one?
Okay. So thank you. So this is the web page that you're welcome to look through to see what we've got in terms of resources, whether they're any use for you. Take what you want, leave the rest. Next one, please. So this is about what education and the education modules that we've got. This is mostly for nurses, particularly nurses in the community and RACFs. So we've got modules about end-of-life care, about advanced care planning in Queensland, because we're a bit of an outrider there. And just in case you don't know or haven't heard yet, on 30th of November, the legislative documents, that is the advanced health directives and the enduring power of attorneys, are all changing. There is no crossover period, so you can use the forms that you've seen before right up until the 29th, but anybody who fills those forms in after the 29th, they won't be valid documents. You need to go over to the new ones. And then that last little button there is about the NICI T34 syringe pump. Next slide, please. So these are about our end-of-life care modules. about symptom management and self-care, which is really important for nurses working in the community. Next slide, please. And these are all the advanced care planning modules about how to start the conversation, about the different types of documents that we have in Queensland. Of course, they'll all have to be updated now, but it gives you an idea of their validity and what needs to be done along with case discussions. Next slide, please. This is the syringe driver package. You may or may not know that there is now a mass palliative care program. They have all sorts of equipment which may be of use for you and your patients. It's really been expanded a lot, and they have everything from continence pads to beds. They're pretty easy to get, they're pretty fast to get. So please, if you need if you think your patient needs any equipment at home, don't hesitate to get into contact with MASS. But the reason I'm talking about them is that they are also, they've ordered a whole lot of syringe pumps so that anybody who needs to be maintained on a NICU at home, they can send them out to them and the nurses can be competent in using them. So with that set of resources, next slide, please. So these are the practical handbook, step-by-step guides, also competency to make sure that the staff know how to use these things. Next slide, please. And we've got a whole lot of videos, of course, about how the pumps work, how to set them up. And next slide, please. So these are just some additional resources, and we've got the information sheet for families. So if you want to introduce your families to the idea of having a pump at home, then you can. Next slide, please. So this is the next project that I wanted to talk to you about, the PalliFarm one. As I was saying, it is really important that people who are dying get easy access to palliative care meds at home, because we know that people who are dying are physiologically unstable, and that symptoms can emerge at any time. If we can't quickly get those symptoms under control, they can escalate, and it may mean that some people who want to remain at home need to be sent to hospital. So PalliFarm is about working with the pharmacists and with GPs to make sure that the pharmacists know your prescribing habits, but also so that you know when you write a script, you will know where to send the people to, or the carer to, that the pharmacist that will have those meds in stock, so people don't have to wait up to 36 hours to get them. The PalliFarm project leverages off, may I have the next slide please, Paige? The PalliFarm leverages off this PalliMeds app. The PalliMeds app, in my opinion, is the bee's knees. This app has been produced by the National Prescribing Service, and it's based on the list of meds that are recommended by the Australian and New Zealand Society for Palliative Medicine for use in people who are in the terminal phase. So it's got all sorts of information about the medicines. It's also got this lovely opioid calculator, so that just by using that calculator, you can quickly convert, say, Tarjan 40BD into a fentanyl driver just with the flick of one of those little buttons there. And it's all evidence-based, and it works in with all the community guidelines. May I have the next one, please? So this is just to give you an idea of what's in that PalliMeds app. We talk about, you know, in palliative care, we use a lot of meds off-label. So it'll tell you how you can work in with the palliative care schedule for the PBS, or how to use other medications. and it also goes hand in glove with the caring at home packages that have been produced and distributed across Australia. Next slide, please. It's very easy to navigate. You can either navigate it by symptom or by medicine. And the symptoms that come up, you can see them there, the common symptoms that people run into: agitation, distressing breathlessness, respiratory distress, seizures, pain, nausea and vomiting. Or you can use this app by looking at the medicines, whatever you've got in your doctor's bag, or whatever may be appropriate. Next slide, please. So in this case, we're just going to say somebody's got the symptom of agitation. You go through, it comes up with the list of meds that are recommended. Next slide, please. And then it will tell you what doses to order if the person's naive or not. These are the list of medications that have been recommended by ANSPAM, and that's what all of that app is based upon. Thank you. Next slide, please. And really, we consider this to be really important because we know that terminal symptom management is really urgent care. And as you know, the general principles for treating terminal symptoms are treat reversible causes, but only if it's appropriate, not if it's going to be burdensome for the person. Use non-pharmacological methods by all means, but often towards the end of life, you really do need pharmacological interventions as well. And I think the important thing is you need to you've got to be prepared to ramp the pharmacological use of the medicines if that's required for the person, because really what we want is a person looking comfortable in the bed, particularly for the family and friends, because that's what's going to remain with them for the rest of their lives. And the other thing is try to determine what worries the person most of all, rather than what worries you. I always have to remind myself of that. And also to prescribe for the background meds, but as well as all the breakthrough agents that you might need. And the final slide, I think. These are the caring at home resources. I hope you know about that. But anyway, these are free boxes of resources that can be used in people's homes and to help them to be involved in symptom management. So I think that's it. Thank you very much. A very interesting looking cat you've got.
Many thanks. Many thanks, Liz. Can you hear me?
Yes, I can. I think I finished, Jane.
Okay, great. Many thanks. Many thanks, Liz. So we might just hold the questions unless anyone's got a burning question at the moment. Okay, we'll just move on and we'll just get Dr. John Harper to provide his presentation now. Over to you, Johnny. Thanks.
So I've just switched presenter to yourself, John. You should get a notification.
Great. Yep. Is that working?
Yep, we can see health pathways. Perfect.
Great. So just, my name is John Harper. I'm a GP in Buderim on the Sunshine Coast and also the GP liaison officer for the PHN. I also am the senior clinical editor for Health Pathways on the Sunshine Coast. A lot of you may already be familiar with Health Pathways. It's a website that's designed for GPs predominantly, but also any health professionals. And it provides clinical decision support tools, as well as a service directory of all the local public and private services. So I'm just going to see if I can do this live, if it's not too laggy. So this is the Health Pathways webpage. you just search up on Google Sunshine Coast Health Pathways, and it'll usually come up as the first option, and you click on that. There's a username which is user SC, and the password which is PWSC, and everyone's got the same username and password, so that makes life easy. So in Health Pathways, you can search using the search bar. Is probably the easiest thing to do. We have a number of palliative care pages on Health Pathways. So I'll just show you this. We've got some sort of an overview of the pages of the main section. We've got quite a good page just about an overview of the principles about palliative care, which is the palliative care overview page. We also have a new palliative care patient. And you'll see with these pages, they all have a similar format, which is we have an assessment step and then a management steps. And we have links to various things. We have drop boxes and links to take you to other pages. In this instance, it takes you to the service page, which we'll have a look at in a minute. I'll just show you as well. You can see down the table of contents, we've got a number of things, and there's quite a few for symptom control in palliative care. So obviously with your palliative care patient, there's a number of scenarios which can come up, and you'll see that there's quite a number of pages. So if we look, for example, at dyspnea, shortness of breath in palliative care, we can step through that. And there are maybe other symptoms as well that we can look at. Delirium. So there's quite a number of pages. When we get to the request parts, which is the request for assessment or referral, you can see these linked to one of these pages, which is an assessment page. And what we endeavour to do is try to incorporate all the public and private services and community services that we're aware of, so that GPs have got all that information in one place. So we liaise with the Sunshine Coast Hospital Health Service to make sure we've got all the right criteria for referral, and the required information for referral. And that way we can support GPs in getting the referrals through to the right place with the right information. Here we have the palliative care day unit, as Louise was talking about. And then at the bottom of the page, we have our private services. And we try and keep this as updated as best we can. Obviously, sometimes it's a bit of a moving thing, but we put them in a directory by region within the coast. And with the contact details and service descriptions, things like that. We also have a palliative care advice page, and as you can see, we've sort of incorporated the Pal Consult advice service as well. And I have to say, I really like the PalliMeds app. I think that's would be a fantastic companion as well. And I was just having a look through before to see if we have any links from our pages to that resource, and I think we're going to have to put some in, because I think that will be tremendously helpful for GPs. So that's really about it in a nutshell. Just to remind you again, the username is user.sc and PWSC is the password, and to get you into Health Pathways. And as you can see, as well as the end of life and palliative care pathways, we've got a whole bunch of clinical pathways in other clinical disciplines, and service directory information as well. So so that's it, really sort of short and sweet, just a bit of an overview there. But if anyone has any questions, then do let me know.
Excuse me, John, do you just want to mention the website page, please?
Which one?
On our website, the palliative care page.
Yes, so on the PHN website.
Hmm.
Yes, or I can see if I can get to it now.
I'll provide the link in the chat too.
Oh, it's scheduled maintenance on our website. So there's if you go to the main page of the PHN website, there's a link across the top to different programs, and one of them is palliative care. I just can't show you at the moment because our website seems to be down at the moment. Never mind.
Thanks very much, John. That was
Thanks,
great.
Jane. Do I stop sharing screen? Yes, there we go.
Yeah, thanks very much. Okay, so I'd just like to introduce our next speaker, who is Alex Moore, who's the CEO of Chidamani. Over to you, Alex. Thanks very much.
Thanks, Jane. We've got the slides. So Chidamani is a specialist home palliative care service. We've been operating on the Sunshine Coast now for actually 25 years this year. We're a community-based not-for-profit organisation and a registered charity. We care for around about 250 families at home annually, and normally would have about 50 families registered on our books. The service is offered free of charge. We receive some funding from a contract with Queensland Health and some local health service funding, and a lot of community support by way of donations and grants. I guess our aim is to provide care at home, holistic, client-centred care at home, to enable people to live their lives at home until their death, if that's what they choose. Symptom management is obviously a very important part of what we do, but we see that as a base really to then be able to provide the psychosocial and spiritual support to give people the support they need at this challenging time of their lives. Next one, please. So as far as our admission criteria go, we look at a life expectancy of probably less than 3 months. Obviously, this is impossible to tell, but because we are limited the number of people we can care for, we try and care for people towards the end of life. We do need them to have a carer in the home because as they deteriorate, obviously it's not possible to keep them at home without that. We work very closely with local GPs. A lot of our referrals are from GPs. So a criteria we have is that there is a GP willing to be involved in their care, and we will work closely with them. They need to reside within the area that we cover, which is outlined here from Caloundra and Landsborough in the south, as far north as Andina and Peregian, and we cover the Blackhall Range, not as far as Mullaney, so Montville, Flaxton and Mapleton. And then we are limited to the number of people that we can provide our care for, and so we need to have space available within our service to be able to take on an admission. That's the main criteria that we have. So next one. Oops, there should be one before that. Services provided, is it there? No, not there. Is it no? Is there one after that? No. All right. Well, I'll just talk about the services provided. It's pretty straightforward. So I guess the core service that we provide is our nursing service. We don't have medical officers as such. As I said, we work closely with GPs and also with Louise's team to provide care at home. Our nurses are all specialists in palliative care. That's the only kind of care that we do. So once a person is referred to our service, we'll contact them and arrange to do an admission. We'll do a detailed assessment and send a copy of that to the person's GP, and then from then on we really work very closely with the GP. So we'll liaise with them closely, we'll contact them with regard to changes. Our nurses are available always. One of our nurses is available on call 24/7 to respond to the person to any needs that come up during that time, which obviously is really important for someone who's at home. When we make that initial contact with the GP, we, as well as our assessment, we will send through a request for emergency medical orders that we will ask the GP to sign, with the option that we always try and contact you first if you would prefer that, or that we can use those medications if the time comes and we can't contact you. So we do carry emergency medications that we can use to cover those kind of emergency situations, but then we would be liaising with you as the GP to write scripts for ongoing medication provision. I guess that a major aspect of what we do is care coordination, so trying to make sure that all of the services that are providing care to the person, that we're all working together. And these days there can be a lot of services there, so that's a fairly important part of what we do. Looking for seamless care, so there's less. It's not disjointed. People feel that people are working together to provide the care that they need. We have a social work team who are also available to our clients. We wouldn't normally involve them without our nurses being involved, just because we have limited resources. So again, they're specialists working in this area. They can provide a range of support, practical support, from a social work perspective, but also counselling support, family conferencing where there's conflicts. So basically the working together to try and provide what's needed to help that family to manage at home. We also provide a fairly comprehensive bereavement support program to all of our clients. That includes the opportunity for face-to-face counselling. We provide regular telephone bereavement support for up to a year after the person has died. And when pre-COVID and hopefully post-COVID, we also run bereavement support groups. The bereavement support groups are open to people other than our clients, but when they start again, but you need to contact us so that we can see that the person is appropriate. We have equipment that we loan free of charge, any equipment that the person might need to manage at home. We have trained respite volunteers who are available to give the carer a break in the home. So whatever we can do to make it possible for the person to manage and to support them. We do provide spiritual care, and we have access to a wide range of spiritual carers if people would like that. So then how to refer is as you see on the slide. We really need you to contact us to discuss with our clinical nurse coordinator, who's available in the office Monday to Friday, whether we have the capacity to take on the person, and also for us to get I guess an idea to make sure that this person is suitable for our service. So if we get a fax or an email referring, we will come back to the GP and check. Sometimes people will self-refer, and then we will always ask their permission to consult with their GP about our involvement and their suitability for our service. So I think that's probably all I wanted to say. So I'm happy for questions later if anyone has any questions. Thanks.
Many thanks, Alex. Okay, so we'll invite Amy Cadd now from Little Haven. Thanks very much, Amy. We can't hear you at the moment.
Can you hear me now?
Yes.
Excellent, wonderful. So yeah, Little Haven Palliative Care, we are a specialist at-home palliative care and bereavement support service. I'll go pretty quickly, Paige, through because there's a lot of slides, but I'll talk quickly. And the next couple is fairly self-explanatory, the next couple of slides about what is palliative care. I think that most people that are watching or involved at the moment are quite aware of those things, but I guess our focus is quality of care and individual care based on what the client's needs are, and that it is a valid treatment option as one of our part of our model of care. So next slide, that our primary objective is to be free as possible from any suffering, maintain dignity and independence, cared for their environment, their choice, have their grief needs recognised and responded to, and part of this is the anticipatory grief. So our staff, our nurses and our social workers and stuff, we do a lot of anticipatory grief counselling leading up to the person's death as well, and to be assured that their family's needs are being met. So we do a very holistic approach and very social based approach to our care. Next slide. So yeah, we do the 24-hour a day on-call specialist palliative nursing. We have social work support that do a lot of advanced care planning, Centrelink assistance, my aged care assistance, and a lot of that advanced care planning paperwork. And we do upload a lot of AHDs and EPOAs and statement of choices to the portal on a daily basis for clients. And we also have volunteer JPs and things like that, so we can get things signed off pretty quickly. We have a huge volunteer army that support our work. So respite care, companionship, practical assistance. We also have our fundraising things. So we have an op shop and a huge range of volunteers that man that. We also do chemotherapy and cancer support. So we have volunteers that go into a chemotherapy unit at Gympie Hospital and do hand and foot massages and make tea and coffee and things like that to support them. Next slide, thanks. So that's patient-centered care. So it's always, obviously, our care is in the home. That's one of our nurses, Kathy, has been with us a long time. I don't know if I mentioned Little Haven's been operating for 40 years, doing what we do. So next slide. So Little Haven today, it started with one nurse 40 years ago. We now have a team of 10 registered nurses or clinical nurses. Allied Health, we have the 2 social workers and a counsellor, admin support, complementary therapists, and I'm aware that that is incorrectly spelt, and respite care volunteers. So we've just had our AGM, which is why I've got these nice figures, easy to hand. So in the last financial year, we had 362 families receiving care, 238 palliative patients, and 124 bereavement support clients. Next slide, please. So in that period, we had 130 clients die in our care, 80% receiving the end-of-life cares in accordance with their preferences, which I think compared to the national average is 20%. Average length of engagement, 166. So we actually really, one of our huge parts of our model of care is early introduction to our services. So often when people first get a diagnosis of a terminal illness, we'll get them on board and start the processing, because it's often quite a long time for people to accept the situation that they're in and look at all the possible support they can achieve. So we've now got Queensland Health and federal funding to cover our care, and so we had to, part of our contract was to get 8,329 occasions, and we delivered 18,058 occasions, with a lot of that being after hours care. The next slide is, I spoke briefly about it, that it is individualised care, and that we do tailor every single person and their family individualised care based on our model. The area that we cover is quite massive. So we do go to the north, up to Tyro, Kilkevin, out to the west. We have Rainbow Beach and Tincan Bay on our east, and down to Boring Point and Pomona in the south. So a 70-kilometre radius, a lot of driving. And the next slide is actually one that I took, one of the clients I was seeing in the community. So this is often what we are faced with when we come back to our car after seeing a client. So we will go into all sorts of situations, particularly in our more regional, rural settings. We also, like Chitamani, will do a lot of equipment hire, and I'm not going to read through everything, but we basically have everything you could possibly need to care for somebody at home adequately, and we hire everything out free of charge. And we also do that a bit in our community, even not for our terminal clients. If we've got people that know about us and just had a knee operation or something, we do short-term loan hire as well. We also have complementary therapies. We can probably go through these pretty quickly, but basically it's part of our holistic approach. We meet needs of clients and their families in many different ways, including lots of complementary therapy, massage, art therapy. A lot of it is care of the carer, because we recognise what a massive job that they're doing, 24-hour care in the home. We have a huge bereavement support program, so it includes telephone and in-person counselling, as well as group therapy and social groups. So we have get-togethers with our bereaved so that they can network with each other and talk about their process of healing. Sorry, I've skipped ahead a few slides. Page, yeah. And then I have talked about, the next slide is about our chemotherapy and renal ward support. So we link in really closely with the renal ward at Gympie Hospital, so that, you know, often, obviously with the renal clients at some point, the treatment's not going to be viable for them anymore. So we try to do early intervention into the renal ward as well, so that that process is linked up. And another part of our bereavement support is we have our annual memorial service where we read out the names of all the clients that have been in our care for the previous 12 months, which is not just for the families of those clients, but it's also for our staff to acknowledge, you know, our grief and our process in all of that. The next slide has just got some quotes with some of feedback that we get from our clients and their families about their care. And I think one of the things is that we, because we're so well established and we've got our model of care down pretty pat, we can get a phone call from a ward about a client who wants to get home before they die, and we've done it when we've got someone home, we've organised it all, and they've died 3 hours later. You know, so we've been able to mobilise really quickly and get everything that's necessary, hospital beds, all the things, so that they can get their dying wishes. And I think that's really important. As far as access to Little Haven, anyone can self-refer, but similar to Chumani, we need to have a GP on board that we can liaise with. We also liaise very closely with the Sunshine Coast Palliative Care Service, and we have people that just walk in the door after they've just been to the oncologist and got this, you know, horrible news about their terminal illness, and we will start from that process of how can we support you best with this situation that you're in. That's some snaps of all the different aspects of our care that we provide. And I guess one of the last slide is that we really do see the importance of early introduction to palliative care, and that, you know, we can have people with really great outcomes and really great palliative process with that sort of support and the adequate support in the community. Thank you.
Many thanks, Amy. That was great. Okay, so we'll move right along to our last speaker, and I'd like to introduce Emma Kerr. Even though it says Pauline Blunden, we actually have Emma, who is the guest speaker tonight from Katie Rose Cottage Hospice. Over to you. Thanks, Emma.
Thank you, Jane. Good evening, everyone. Thanks for having me here tonight. Pauline sends her apologies. She's unable to attend tonight, so I'm the acting CNC at the moment at Katie Rose Cottage Hospice. Just a couple of slides tonight and a few things to go over. Katie Rose Cottage Hospice was established, as you'll see there on the slide, in 2006, but the current statistics that I'll present on the next slide refer to the period between August 2018 to the current period of time. We're located in Doonan in the Noosa hinterland. We've got a 3-acre property, some amazing gardens and bushland, and attached to the hospice. We service the Sunshine Coast and beyond, as it says there, 24 hours a day, 7 days a week. We have 13 registered nurses, and we work very closely with GPs, obviously, and the palliative care specialists through Sunshine Coast Pal Care. We're a fully accredited hospice, providing a home away from home environment, We are a charitable organisation, and our model of care is based on a collaboration between RNs and GPs, and as I mentioned, Queensland Health Palliative Care and Counselling Support Services. We are currently a 3-bed facility site organisation, and we do have plans to expand, but obviously that comes at a cost. And given that there is no cost to the guests who stay and access our palliative care services, we welcome donations to the hospice. As I mentioned, we are accredited, and we received that full accreditation in June 2019. Similarly to Amy and Alex, in terms of the volunteers across the organisation, we have upwards of 300 volunteers that support our organisation through our op shops and other fundraising events and things that we host. If we could maybe go to the next slide, please. So this snapshot, as I mentioned, is provided since the 6th of September in 2018 to almost the current period. So we serviced 118 guests during that time. Our occupancy was around about 60%. 47% of referrals received from a hospital setting and 40% from GPs. Average guest length of stay around 10 days, and the average age of our guests at the moment is sitting at 73, although that does obviously fluctuate. We have single rooms, so all of which have ensuite facilities, provisions for family members and loved ones to stay with the loved one in the hospice overnight and during the day. In relation to our admission criteria, basically, as I mentioned, we're a 24/7 hospice, so there's always a registered nurse available at the hospice itself, and out of hours, either Pauline or myself are available via phone to speak with if the matter's urgent and the registered nurse feels that we need to be across something that's happening in the community or in the inpatient setting. The patient's guests need to have a progressive life-limiting illness with the expected end-of-life prognosis somewhere around the 6-week mark or less. And the guest or their decision maker needs to understand and agree to, obviously, the provision of palliative care, with the primary goal being around symptom management, maintaining quality and comfort at end-of-life care, and also similarly to Dove, which Louise mentioned, a not for CPR resuscitation order is required and documented on admission. And obviously we work quite closely with Chittamani and Littlehaven in regards to referrals and community GPs. Our guests do have a choice of personal GP if they wish. We also have a dedicated group of GPs who do provide support 24/7 to our guests. And that's always a discussion that we have prior to admission to ensure that that smooth transition, either from the community or from the inpatient setting, is managed when they're admitted to Katie Rose Cottage Hospice. So yeah, a very unique setting, a very beautiful environment for palliative care, end of life, and something that we work quite hard with in terms of the community to encourage people to come and have a look at what we're about and where we are, to ensure that the environment and the setting that we are is understood by guests and their loved ones. And often we have people that come and have a look around many, many months before they need us, so that, like I said, that transition is made as, you know, I guess as comfortable and as smooth as it can be. So yeah, that's basically what I wanted to share with you tonight. So thank you.
Many thanks, Emma. That was great. So we're tracking well to time. I just want to thank all our speakers this evening. And so we'd just like to use this last 10-15 minutes to open it up to the floor. And if there are any questions, if you could please just fire away, and we'll and just say who you'd like the question to be directed to. Thank you. Any questions? While we're waiting for people to speak, we will, as you can see in the little grey section on the right-hand side of your screen, we have provided 3 handouts for this evening, which covers most of the information. You will be receiving some information tomorrow. We'd like you to complete an evaluation. And we'll also, I think we're providing that in the chat section as well. We might provide the link for you before we close this evening. And we will be providing the recording. So if you want to share it with any of your colleagues, the information's there for them to refer to also. If you want any further information around health pathways, you can actually contact Dr. Harper, and he can provide some information directly to you at your practice. And all the other information around the services are contained within the slides as well. So do we have any questions? Don't be shy. Oh. Okay. All right. Before we close, do any of the presenters want to have any last words before we go? No? Okay. Well, thank you all very much for your time, and we hope all of our guests who are listening enjoyed the sessions tonight. And good night, everyone, and thanks for joining us.
Thank you. Bye.
Good night, everyone.
Good night.
Thank you.
Bye.
Bye.
Thanks, everyone.
I'm not sure if I've stopped the broadcast.